morning, good afternoon, good evening from wherever you are, everyone. Welcome to another Health for the World International Grand Rounds. We're back, new school year, academic year, and today we will be talking about Hodgkin's lymphoma. So I'd like to take the opportunity to introduce our speaker, Dr. Abuali. She is a distinguished hematologist oncologist at Massachusetts General Hospital and instructor at Harvard Medical School. She earned her degree at Alexandria Faculty of Medicine and completed her residency at St. Agnes Healthcare and pursued her hematology oncology fellowship at the University of Cincinnati. Dr. Abuali will be speaking today on the management and classifications of Hodgkin's lymphoma. So we are very, very excited to have her back, give this amazing talk, and hear all about her expertise in the field. So thank you, Dr. Abuali, for joining us. Thank you, everyone else, for joining. And let's learn about Hodgkin's lymphoma. Thanks.
Thank you so much. I appreciate you. And I am really excited to chat with all of you today about one of my favorite things to teach, Hodgkin lymphoma. So I am a hematologist and oncologist. I do a little bit of everything. I do round a lot on our lymphoma services here. And this is one of my favorite topics to teach because you can really condense it all in a 45-minute lecture and really hone in all the major trials. And so let's dive into it. So I like to start my talks by honing in on the key learning points. So my goal today is at the end of the following 45 minutes, we're all going to learn those key points about Hodgkin lymphoma. So the first point is that Hodgkin lymphoma is an aggressive B-cell lymphoma, but it is also highly curable. Chemoradiotherapy for early stage disease is very effective. And as we have worked throughout the years on figuring out how to make our therapies less toxic, we've utilized PET-adapted therapy approaches to figure out how to de-escalate our chemotherapy or how to minimize the radiotherapy we're giving patients while maintaining efficacy. If your patient has advanced stage disease, then combination chemotherapy regimens are highly effective. In more recent years, adding brentuximab has really helped improve progression-free survival and overall survival. And then most recently has been immune therapy and its emerging role, both in advanced disease and relapsed refractory disease. So those are the main things we're going to learn today. So let's dive a little bit into epidemiology. So when you think about lymphomas in general, we tend to put them into two buckets, right? Hodgkin lymphoma and non-Hodgkin lymphoma. And Hodgkin lymphoma tends to be quite rare overall. And while it's aggressive and can have more of an aggressive presentation and advanced presentation up front, it's really highly curable. We tend to see this bimodal age distribution. So it happens in our younger adults in their 20s and then peaks again in our older adults, age 60 and upwards. Slightly more common.
Doctor, please,
Yes.
we're really sorry to interrupt you, but we can't see the slides move. We are still on the title slide.
Oh.
Yeah, Doctor. Oh, yeah, now it's moving. Maybe also if you click the bottom button, there's a square with a line in it to the right. One more. Yeah, that one. If you click that too. Let's see.
Are you seeing epidemiology?
We are now, but it's not in big screen.
Are you seeing me flip through it?
No.
Huh.
Do you have multiple screens by any chance?
No.
Sorry, maybe let's try. Oh, maybe at the top next to the save button, if you go two over, there's there's a box with a play sign.
Let me see. Get that. Okay. Are you seeing title slide?
No, we're on key learning points.
Okay, key learning points. And then are you seeing epidemiology?
No.
Huh. Okay.
Oh, now we are. Yes.
So I guess it's not letting me go into full screen mode for some reason. Are you guys able to see, like, are those slides big enough to be viewed at your end?
Yeah, they're probably fine. Yeah, as long as when you move, we're able to see them move. I think it should be fine.
So you're able to see me move through slides?
Yes.
Yeah.
Okay, I'm sorry about that. Not
And
the best start.
no,
But
great intro.
the one slide that you all missed was just the slide summarizing the key learning points for the talk for today. And then I had just started onto our epidemiology slides. Thanks for letting me know the slides weren't showing. So when we talk about epidemiology, I was just saying that it is a rare B-cell lymphoma that is aggressive but highly curable. Tends to occur in our patients in their 20s and then our patients in their 60s and above. A little bit more common in men as compared to women. It has an association, different risk factors with viral infections like EBV and HIV, and in patients with an immune suppressed status in general. And then we note that there is this genetic alteration that we see in the PD-L1/2 genes in classical Hodgkin lymphoma. And that's where immune therapy has really emerged to be effective, especially in the more advanced and relapsed refractory stages of the disease. So let's start with a clinical case. So a 35-year-old patient presents to the emergency room, has no significant past medical history, complaining of a 15-kilogram weight loss over the past 6 months and having drenching night sweats and fevers of 101. And then on examination, he was noted to have bilateral axillary lymphadenopathy. CT chest, abdomen, and pelvis were done, and it showed diffuse lymphadenopathy, axillary, mediastinal, and inguinal. And so as the on-call oncologist, you get consulted for this patient and what is the next diagnostic steps and how do you start thinking through the workup here? So as most lymphomas tend to present, Hodgkin has also a similar presentation where patients will come in with painless lymphadenopathy, right? The lymph nodes usually don't hurt unless there is some superimposed infection somewhere. They can come with the classic B symptoms, fevers, night sweats, and weight loss. And the big symptom is fatigue, as patients have just not felt well and have had this crushing fatigue over the past several months. When we think about our workup, a big thing to bear in mind is that you do not want to do a fine needle aspiration biopsy. If you only do an FNA in any type of lymphoma, really, you're not going to be able to pick up the malignant cells. You need to get more of your tissue. Traditionally, we would love if we can get a full excisional biopsy in Hodgkin lymphoma because in a lot of cases, there is so much background inflammation that you're not really able to pick up the malignant cells if you get a smaller piece of the tissue. So if you have a more peripheral lymph node, like an axillary or an inguinal lymph node, and you can get an excisional biopsy, that is the most preferred gold standard way of diagnosis because you can really look at the full lymph node architecture and be easily able to get a diagnosis. However, if your lymph nodes are too deep, like you've got mediastinal lymph nodes, retroperitoneal lymph nodes, a core biopsy is your go-to. It's what you have. Just make sure that you're getting sufficient tissue so you can actually pick up the malignant cells. And the malignant cells here are the Reed-Sternberg cells. This is what you see in the classic Hodgkin lymphoma. And they tend to be there hiding in this background inflammation that you see on histology. And a lot of the patients will have a positive EBV as well on their sample, because as we said, there is a lot of viral association with this type of lymphoma. And then things that you think about as you start doing your workup, you're getting your full lab workup, your CBC with differential, your CMP, your ESR. The ESR as a measure, as an inflammatory marker measure, has some prognostic connotations in Hodgkin lymphoma. As with any type of lymphoma, you always want to see if there is an association with other viral diseases like HIV, hepatitis B or C. If you have access to PET CTs, and I know it's not easy access everywhere in the world, but if you do, it is preferred to have a PET CT for baseline staging and to use that throughout the rest of your treatment course. You don't usually need a bone marrow biopsy for staging if you're able to get a PET scan, because the PET scan has very high sensitivity and picking up the avidity in the bones. And then other things you start thinking of before chemo planning are an echocardiogram, because some of our chemotherapies can be cardiotoxic and you need to know your baseline EF, pulmonary function testing, because some of the chemotherapies like bleomycin can have toxicity on the lungs. And then it's very important and is often forgotten to have fertility preservation discussions, especially in our younger patients, because a lot of the chemotherapy combinations we use can be gonadotoxic and really impact patients' fertility down the line. And because this is a highly curable lymphoma, you really want to start thinking upfront about survivorship and long-term side effects that can happen from the therapies we use. So that's the workup in a nutshell. You know, your biopsy, your staging with scans, and some things that you do for chemotherapy planning. And then as you think, the same way you put lymphoma in buckets, Hodgkin lymphoma and non-Hodgkin lymphoma in itself is also divided into the classic Hodgkin lymphoma, which is the majority of the cases that we see, and nodular lymphocyte predominant Hodgkin lymphoma. So NLPHL is quite rare. It only makes up about 5% of Hodgkin lymphomas and is very distinct, has this very different histologic features. Classic Hodgkin lymphoma is further divided into 4 subtypes, and we're going to talk a little bit more about the 4 subtypes in future slides. So again, when we think about the classification, you have your Hodgkin classic lymphoma and you have your NLPHL. The classic Hodgkin lymphoma is what has the Reed-Sternberg cells, which what we characteristically say have this owl eye appearance, that it looks like owl eyes on there. And when you stain it on histopathology, it is classically positive for CD15 and CD30, but doesn't carry the B cell and T cell markers. In contrast, when you look at NLPHL, the cells here are very distinct. You get the popcorn cells, which has more peripheral nucleoli and lobulated vesicular nuclei. And this tends to carry different markers. So it carries the B cell markers and some of the T cell markers. So it's CD15-30 negative, but tends to be positive for things like CD19, 20, 45, 79A, and so on. And then when we dive more into the classic Hodgkin lymphoma itself, it has 4 subtypes. And again, the 4 subtypes are also distinct in terms of the epidemiology, in terms of how they present, and even in how their histology looks like. So I originally practiced in Egypt. And so as low middle income countries, the one we actually saw the most was mixed cellularity Hodgkin lymphoma, which tends to occur more in the pediatric population and in the older population, has a strong association with EBV, and tend to present more in advanced stages, affecting the bone marrow and the spleen, and it would have epithelioid granulomas on histology. I now practice here in Boston, in the US, and in high-income countries. The one we actually see more commonly is the nodular sclerosis subtype, which is not usually linked to EBV and occurs more often in younger adults and tends to be picked up in early stage diseases and has mediastinal cervical supraclavicular lymph node distribution and has this characteristic inflammatory background. And then 2 other subtypes that are less common are the lymphocyte rich and the lymphocyte depleted. The rich subtype tends to present in earlier stages as compared to the lymphocyte depleted, and they also have different histologies. So there's a little bit of variation here in the classification of Hodgkin lymphoma that affects how the patients present, how their histology looks like, and has a little bit of a prognostic connotation to it as well, just by virtue of the fact that some of them present more in earlier stages compared to others. So Hodgkin lymphoma, you have classical Hodgkin lymphoma, that will be the bulk of our talk, and it has the 4 subtypes. But a quick word on the other distinct entity, the NLPHL. This one tends to occur more in middle-aged women, occurs in earlier stages. Patients will come in with peripheral adenopathy, and they're actually CD20 positive. And so the treatment regimens for those are very different. They're usually rituximab based because you're trying to target the CD20. And some of those patients will transform to non-Hodgkin lymphoma down the line. So that is just a different, distinct entity from the classical Hodgkin lymphoma, which will be the bulk of our talk today. And then when you think about, well, how do I stage the lymphoma? As with any other lymphoma, you use the Ann Arbor classification for Hodgkin's lymphoma. And when you're using your PET scan, your line is always the diaphragm to figure out if someone is early stage or advanced stage. So as we know with Ann Arbor, the stage 1 is when you have lymph nodes only on one side of the diaphragm. So just a single group of lymph nodes. Stage 2, you have 2 or more groups of lymph nodes, but they are all on the same side of the diaphragm. When you start going above and below the diaphragm, then you're stage 3. And then stage 4 is when you have this widespread metastatic disease that is now affecting the bones and the organs. And A and B means you have either no constitutional symptoms or you have constitutional symptoms. And this is just staging in a nutshell. Stages 1 through 4, with 1 and 2 being early, 3 and 4 being advanced. And then A or B means, do you have constitutional symptoms or do you not have constitutional symptoms? And when you try to think a little bit further about it, you can subdivide it more from a prognostic standpoint into early stage favorable or unfavorable. And you can also prognosticate your advanced stage. So if you have stage 1 or 2, you're above or below the diaphragm in one area, you are just favorable. But then you can pick up some unfavorable risk factors if you have bulky disease, if you have several lymph node and groups involved, 3 or more, when you have B symptoms, when you have extranodal disease, and when your ESR is elevated, 50 or higher. So those are unfavorable risk factors. And this becomes important when it comes to treatment, because treatment is different based on are you a favorable early stage or an unfavorable early stage. And then for advanced stage, we use the International Prognostic Score, the IPS, to figure out what risk factors your patients might have that confer a worse or a riskier prognosis. So you pick up points by being a man, being 45 years of age or older, having stage 4 rather than 3, having a low albumin count, being anemic, having leukocytosis or lymphocytopenia. So all of those confer points on the IPS. So we've learned how to classify lymphoma, how to stage lymphoma, and how to think about it in terms of risk stratification and prognostication. Now we're going to dive a little bit on a few basic therapy concepts to set the stage. So one important thing to think as we go into therapy is that the PET scans that you use down the line, you use one for staging initially, but you're also going to use them to monitor therapy. We'll use something called the doable response assessment to figure out how much did the patient respond to the treatment you gave them. And the DS on the PET CT is assigned based on the uptake. So the uptake here, when you look at the PET scan here, this is considered no uptake. And then you start having a little bit of uptake equal to or below the blood pool is a DS2. DS3 is when the uptake is below or equal to the liver. 4 is when it's higher than the liver, and 5 is when you're starting to have new uptake in new regions. And so this is what the report means on the PET scan when the radiologist writes if it's DS1, 2, 3, 4, or 5, because that is very important. Usually when you have DS1 or 2, you know that the patient is responding to treatment, but especially if they're having 4 or 5, then you know that the current therapy you have is not working and that you need to escalate or further intensify your treatment. And in a nutshell, when you're thinking about treatment, as we go through the next upcoming slides, for early stage, you utilize combination chemotherapy. So it's either going to be ABVD or BACOP based on where you practice in the world, and radiation therapy. So chemo combined with radiation therapy really has more than 90% cure in the frontline setting for those patients. And then for more advanced stages, there is no role for radiation here. It is systemic therapy. So if you practice in the US and North America in general, ABVD is the regimen that had been utilized. In Germany and some parts of Europe, they use BIACOP, a different combination of chemotherapy regimens, and it's been recently switched to BR-ECAD based on more recent data. And then in 2018 is when brentuximab was approved based off the Echelon trial, and people started using brentuximab instead of bleomycin was the AVD. And most recently in 2023 was when the data came out about using nivolumab immune therapy with AVD. So this is really a nutshell of everything we're going to discuss in the upcoming slides and as we dive more into the data that brought this forward. And as we look, these are just refresher slides. They're just there for your own review later on. But for ABVD, as you all may know, is a 28-day cycle. It's a combination of 4 different chemotherapy drugs. They're all given through the IV, and the treatment is on days 1 and 15. So it's doxobliovin and the carbazine. And then for escalated BIACOP, which is a regimen we don't usually utilize here in the US in the front line, but they use it in Germany and in Europe, it's a 21-day cycle and is a little bit more complex in terms of the additional chemotherapy drugs it uses and how it is dosed. So those slides are just for reference. And then for brentuximab, which I know is not approved everywhere in the world, is not approved, not available everywhere in the world. But brentuximab vedotin is an antibody drug conjugate. And so what it does is it goes and latches on the CD30 marker that the Reed-Sternberg, the malignant cells have. And then it gets incorporated inside the cancer cell where it releases the MMAE portion of it, and this is the portion that causes cell cycle arrest and cell apoptosis. So it's a novel antibody drug conjugate that specifically targets the CD30. And then for immune therapy, as you all know, nivolumab is an immune checkpoint inhibitor. So usually in our bodies, we have our T cells, we have our own immune system, and when our own T cells try to attack the cancer cells, what happens is an interaction happens between PD-1 and PD-L1, PD-L2 that pumps the brakes, and the T cell cannot kill the cancer cell. So when you use an immune checkpoint inhibitor like Opdivo, it removes this checkpoint, it removes this brake here so that the patient's own T cells can get activated and kill the cancer cells. And that's just the mechanism of action for immune therapy drugs. So when you think about Hodgkin lymphoma treatments, you've got your traditional cytotoxic chemotherapies with ABVD and BIACOP. You have your novel antibody drug conjugate with the ADC with the brentuximab, and you have your immune therapy with nivolumab. And essentially what we're going to talk about moving forward is how do you combine all of those different things together. So for early stage favorable Hodgkin lymphoma, the landmark trial that looked at this was the GHS-GHD10, and this was a while ago. This was now almost 15 years ago, back in 2010, that looked at patients with stage 1 and 2 who were early favorable, so they didn't have any of those risk factors, and try to figure out, do we give 4 cycles of chemo and 30 degrees of radiation? Do we do 4 cycles of chemo and 20 grays of radiation? Do we do 2 cycles of chemo and 30 grays, or 2 cycles of chemo and 20 grays? And essentially what it ended up showing is all those patients had pretty much similar overall survival rates. And so the less is better, right? Because you want to save the patient from a lot of toxicities. And so this is what unified the standard of care of giving 2 cycles of ABVD followed by 20 grays of radiation for patients with early stage favorable disease. And so this became the standard of care, years ago when this data first came out. And then over time, people started worrying, well, a lot of my patients are younger patients. And for example, if they have mediastinal lymph nodes and I'm giving them radiation there, they are at risk for getting secondary malignancies like breast cancer, or they're at risk of heart disease down the line. And so several trials started looking at how can we modify this regimen and start doing things a little bit differently. And so you can get rid of the radiation altogether and just do 4 cycles of the chemotherapy, as long as your interval PET looks okay. Or you can do 2 cycles of ABVD and then drop the bleomycin and then just do 4 more of AVD only. Or you can just do 3 cycles of ABVD, or you can do 4 cycles of ABVD. So different trials really came out in the following years just to try to figure out how to get rid of the radiation if it's considered high risk, and how instead to substitute with chemotherapy and use your interval PET scans just to make sure that you're de-intensifying therapy properly. So any approach is really okay, and it's tailored to the patient. You know, how old are they? What is their risk for secondary malignancies and cardiovascular disease? And then I just like adding slides for references, so you all can have the slides after the talk just to refer to things or dive more into details. But this is essentially, when you go to NCCN guidelines, this is what it says, that you do the 2 cycles of ABVD, and then you have all those options of de-escalating your chemo, of doing radiation, of dropping the bleomycin. Like, you can do it in different ways and tailor it to patients. And this is another reference slide that I'm just keeping for all of you as well to review. It was from the ASH Hematology Review Series, and it summarizes those main trials that approved those different combinations of treatments and how to intensify and de-intensify therapy. So for the early stage favorable, you can do 2 cycles of chemo followed by radiation, or you can get rid of the radiation altogether and figure out a way to work around the chemotherapy for your patient if you're worried about concern for long-term radiotherapy toxicities. Now, those were favorable. If your patient has unfavorable early stage, so they have one of the risk factors we had talked about before, for example, bulky disease or involvement of several lymph node groups, then you need a little bit more intense therapy to make sure that you get rid of the disease. So the combined chemoradiotherapy approaches here are a little bit more intense. So instead of just 2 cycles of chemo, here you're doing 4 cycles of the ABVD, and instead of the 20 grays of radiation, you're doing 30 grays of radiation. And then, as I had mentioned before, the escalated BIACOP regimen is used a lot in Europe, and sometimes people would just do 2 cycles of the escalated BIACOP and then do 2 cycles of ABVD followed by the 30 grays of radiation. So both have been approved back in 2011 and 2012 based on those 2 trials. Or again, if you do not want to give radiation to the patient and you're worried about the toxicities and you want to do chemotherapy alone, you can do, again, 2 cycles of ABVD and de-escalate it to 4 more cycles of AVD afterwards, or you can just do 4 cycles of ABVD and you're done. So it's always a discussion with the patients about risks and side effects of radiation and chemotherapy, especially in the long term, because as we said, those patients have really excellent cure rates, and so you want to minimize toxicities down the line. And again, some more slides for your reference. When you look it up in the NCCN guidelines for the stage 1, 2 that are unfavorable, again, you can start with your 2 cycles of ABVD and then accordingly decide, are you going to do 2 more cycles with radiation? Are you going to drop the bleomycin and just do AVD? Or, of course, if the PET-CT shows that the treatment you gave was insufficient, and the doable is still 4 or 5, then you need to escalate your treatment and intensify it with something like BIACOP. And again, another reference slide, and it specifically highlights just all the major trials where the different regimens were decided on. So again, just for your review. So that was early stage. So early stage combination of chemotherapy and radiotherapy or chemotherapy alone has excellent cure rates, and most of our patients can live for a very long time following our therapies. Now let's dive more into advanced Hodgkin lymphoma. So those are our stage 3 and 4 patients. So a few key trials where all the data comes from. There is the trial that showed the use of the PET scans to what we call PET-adapted ABVD approach. There is the trial that looked at escalated BIACOP and how to intensify or de-intensify therapy based on the PET scans. There is a trial that compared ABVD to BIACOP and noted no survival difference. And that's why a lot of us here in the US will just utilize ABVD instead of BIACOP. Most recently in ASCO, this 2 months ago, was the trial that looked at simplifying escalated BIACOP and using instead brentuximab along with ECAD, which had better progression-free survival and overall survival. There is the Echelon trial that looked at adding brentuximab to AVD in advanced stage Hodgkin lymphoma. And there was the SWOG group trial that showed that nivolumab addition to AVD improves progression-free survival compared to brentuximab, and how this is utilized more in our older adults now. So those are the key trials that we're gonna go over quickly now. So the first one, the one that talks about response-adapted therapy for advanced Hodgkin lymphoma, the big thing is we're really trying to think, how much bleomycin do we really need to give our patients, and when can we get rid of the bleomycin? Because we know that using a lot of bleo can be toxic to the lungs and can have a lot of significant side effects. So in this trial, patients got 2 cycles of ABVD, and then if their PET-CT looked good, then the patients were randomized to either continuing with ABVD or getting AVD only to try to assess whether we can get rid of this bleomycin early on. And what this trial showed was omission of bleomycin in this PET2 was non-inferior. So the patients who continued getting ABVD versus the patients who dropped the bleo and just got AVD, both of them really at the 3-year PFS was pretty comparable. And so the standard of care now is that you really try to omit the bleomycin as soon as you can, because we don't want to use too much of it in our patients. The HD18 trial, the one that looked at escalated BIACOP in advanced stage Hodgkin lymphoma, also tried to figure out how much of this chemotherapy should we really be giving our patients, and tried to look at whether it's reasonable to de-escalate and give less cycles. And what we found from this trial is that for those patients, if after 2 cycles of BIACOP, their PET scan looks okay, and by looking okay, I mean that the DS is 1 or 2, then if when they were randomized to 4 further cycles of BIACOP versus 6 to 8, really less is better. As often is in oncology, the less chemotherapy you give patients, the better. And so before, we used to give a lot of treatment, but now we know that if the PET scan looks okay, you can just de-intensify, give 4 more cycles, and you're done. And the big question that came afterwards, well, we have data looking at ABVD and we know it works, and we have data looking at BIACOP and we know it works. Which one should we use? And this trial here that was published back in 2011 compared ABVD to BIACOP to try to see whether one was superior to the other. And what was noticed was that there really was no difference in survival. And overall survival at the end of the day was pretty comparable. Some people argue that with BIACOP, you can get earlier control of the disease if patients have bulky disease, and you can get a little bit of faster response initially, but ultimately the overall survival is similar in both patient groups. And so a lot of folks feel that while there are more toxicities with BIACOP, there is an increased risk of infertility, there is an increased risk of secondary leukemias down the line. And so a lot of people opt to using ABVD instead of BIACOP, at least here in the United States, where it's really just stayed as standard of care treatment option for our patients with advanced classical Hodgkin lymphoma over BIACOP, just because we didn't really note any significant improvement in overall survival. And then most recently, this past ASCO in June, was this trial that looked at adding brentuximab and doing some substitutions to this chemotherapy regimen to try to make it a little bit less toxic and a little bit more effective. And so the backbone, the chemotherapy backbone of cyclophosphamide, doxo, and etoposide remained as is, but we got rid of the bleomycin, which, as we know, causes the pulmonary toxicity. We got rid of the vincristine that causes the neurotoxicity and added the new antibody drug conjugate, the brentuximab vedotin, instead. We also used the carbazine instead of procarbazine and simplified the steroid regimen. And what was noted with this regimen is that this regimen has better tolerability and has improved progression-free survival. And so a lot of folks in Europe now are shifting their practice towards using this over the escalated BIACOP based on this trial data. But because the data is so new, it hasn't really made its way into NCCN yet, I think. And then the Echelon-1 trial, which is another landmark trial in Hodgkin lymphoma, is the one that looked at brentuximab. And so for many years, the standard of care was just ABVD, and we didn't know how to improve on ABVD until this trial came along and substituted the bleomycin with the brentuximab. And what was noted was the 6-year progression-free survival. Adding brentuximab improved progression-free survival, and more importantly, it improved overall survival. And because overall survival is so good in Hodgkin lymphoma in general, you can see the ABVD arm, the overall survival was already close to 90%, but you can see the additional benefit that we gained from utilizing brentuximab instead of bleomycin. And that improvement in overall survival was actually consistent across all the subgroups. Now, the big thing, while brentuximab does not affect the lungs, does not cause the pulmonary toxicities that the bleomycin did, it causes less second malignancies, it causes less progression of disease. And so we favored using brentuximab. It's important not to forget about the big side effect that occurs with brentuximab, which is the peripheral neuropathy. And so especially if your patient is older and has some baseline peripheral neuropathy to begin with, adding brentuximab to this regimen can cause high rates of peripheral neuropathy. And we can see in that patient arm, after 2-year follow-up, 67% of patients actually had some grade of peripheral neuropathy. Now, the good thing is it is reversible, and over time, it tends to resolve and improve. And so the majority of the patients on the 6-year follow-up, 86% of patients had the peripheral neuropathy resolve, but it can actually take a long time for it to resolve, a few months, and can be quite distressing to patients. So just something to always think about is that while brentuximab AVD has a better side effect profile in one aspect, it can also cause increased risk of peripheral neuropathy for our patients. And so you have to bear that in mind when selecting your therapy. And so we were very happy in 2018, when this data came out and we were doing brentuximab with AVD and we had such good overall survival rates. Now, the problem came when we were trying to treat older adults, so patients who are above 60 years of age, because that still makes up a big proportion of our patients, 15 to 25% of our patients. And a lot of them really had a lot of difficulty tolerating our treatment, tolerating several cycles of ABVD or brentuximab AVD. And so we would have to keep cutting down on the doses. And that meant less efficacy and lower survival rates, especially with the brentuximab. And so that latest trial, the SWOG S1826, looked at, well, what if we utilize nivolumab as immune therapy instead of brentuximab, and see if that can help our patients and be a little bit more tolerable. So patients who are randomized, some of them were getting brentuximab AVD, and the other arm was getting nivolumab AVD, and still following the day 1 and 15 on our 28-day cycles. And what we found with this trial was that the nivo arm had better progression-free survival compared to the brentuximab arm. And a big part of this was because patients on the brentuximab arm, we had to keep cutting down on their chemotherapy or delaying their cycles, so they weren't getting as much therapy as the arm that was getting the nivolumab. And when we look at it across all the different subgroups, especially for patients who were above 60 years of age, you can see that there was the trend overall favored the arm that received nivolumab. So even though it was all geared towards favoring nivo AVD, the effect was particularly prominent in our older adults, so patients above 60 years. And so basically what came out of this is this conclusion that, well, now we know that we can utilize nivolumab AVD for older patients who are fit to get the AVD portion, but maybe might struggle a little bit with the addition of brentuximab there, and that this therapy is a little bit more tolerable. So when you put it all together and look at the NCCN guidelines for advanced stage Hodgkin lymphoma, you can see that the two category 1 regimens are the ABVD and the brentuximab AVD, and it has disclaimer on it, right? Contraindicated in those with neuropathy. And you use, your PET scans to figure out how much chemotherapy to give and how to de-escalate and how to escalate. And here it's made its way into the guidelines that we can use the brentuximab ECAD or the nivolumab AVD, but it just mentions useful in certain circumstances just because this data is more recent and newer as compared to the rest of the data. So that's the NCCN summary of all the trials we had discussed. And finally, just to kind of wrap it all up, a few quick additional points to bear in mind. If even though we have excellent cure rates, excellent overall survival in our patients, some people will still have relapsed and refractory disease. A few key points to remember for those patients is if your patient is chemosensitive, you can still give salvage chemotherapy and aim to take them to stem cell transplant, because auto stem cell transplant actually cures about 50% of those patients. And there is a lot of data that looks at using brentuximab for consolidation after the transplant or after relapse following the transplant. And same for immune therapy, where immune therapy has an emerging role here and can really be added to different salvage lines. So this slide, again, just there for your reference, but it shows all the trials out there that have really tried to look at all the different salvage regimens we can use, where you can use brentuximab and then chemo. You can combine brentuximab with chemo. You can actually combine brentuximab with immune therapy. You can give immune therapy, then chemo, or immune therapy and chemo. So many, many different combinations out there. And when you look at the progression-free survival, there are actually pretty good numbers and good data out there. So even if the patient ends up developing relapsed disease, there are still many good and effective options that can be utilized. And no talk about Hodgkin lymphoma is complete without stressing on the survivorship aspect of it, because as we said, those patients hopefully will have a long life expectancy, and we want to make sure that we mitigate the toxicities of therapies down the line. So it's important to think about things like infertility and secondary cancers that can occur from our treatments. They're more pronounced with BIACOP over ABVD. But something to bear in mind, and fertility discussions before starting treatment are very important. There is no benefit to routine surveillance scans. Those patients just follow with their oncologist or down the line with their primary care physician for a history and physical exam. And for a yearly CBC, because there is always that risk of developing secondary leukemia or MDS down the line. So keeping an eye on the CBC is important. The risk is much lower with ABVD compared to BIACOP, but it's still there. The radiation in itself, as we know, can have a lot of side effects in terms of increased risk of breast cancer and increased risk of cardiovascular disease. So it's important to think about mammograms for patients who've had mediastinal or axillary radiation. We usually start the mammograms 10 years after treatment or when the patient turns 40, whichever comes first. And if it's a young patient that you have, less than 30 years old, where a mammogram is not going to be very sensitive, then we should consider MRI breast for those patients for monitoring. And then cardiovascular risk assessment and management is a big thing after radiation therapy to the mediastinum. So aggressive risk medication, mitigation, counseling about diabetes, hypertension, smoking cessation, considering carotid ultrasounds if your patient had received neck radiotherapy. And some folks even take it a little bit further by considering a stress test or echo every 10 years. Especially for patients who've had radiotherapy a longer time ago, where the techniques were not as precise as they are now, and the risk of side effects were higher. And that just brings up to our key learning points, which we had started at the beginning of the lecture. And again, to go over them quickly, Hodgkin lymphoma is an aggressive B-cell lymphoma that is highly curable. For early stage disease, a combination of chemotherapy and radiotherapy is very effective. PET-adapted therapy approaches help prevent toxicities while maintaining efficacy and can help guide you about how to maybe lose the radiation altogether or de-escalate your chemotherapy as appropriate. Advanced stage disease has this combination chemotherapy regimens that are utilized, ABVD or BIACOP, and adding brentuximab vedotin in the past few years has really helped improve progression-free survival and overall survival for patients. And finally, immune therapy has an emerging role in advanced disease and relapsed refractory disease. And that brings me to my end of the talk, and I am happy to take any questions.
Thank you so much, Dr. Abuali. That was an absolutely fantastic talk. Thank you for your time and your expertise. And as you mentioned, we'd love to open up the forum for any questions that anyone may have. And I'm happy to start with a couple of questions I have as well. And while we're waiting, I noticed towards the end of the talk that you had mentioned that some of these drugs tend to have special considerations for certain patients. You had mentioned specifically brentuximab and nivolumab, and I wanted to ask if there were any significant differences in terms of accessibility for certain patients in certain regions of the world that you might be aware of, or even in the United States, that might kind of impact our decision and ability to give these targeted therapies to patients.
Yeah, absolutely. So I mean, like I'd mentioned earlier, I practiced in Egypt before moving here to the US, and it's really hard to have accessibility for either brentuximab or nivolumab. Like immune therapy in many parts of the world is not readily available. And even here in the US, it's harder in certain areas. Like I have the privilege of working in an academic center, so we are able to give access to our patients for immune therapy. But if you work in more rural communities, even here in the US, it's harder to access immune therapy for patients. And I've given this talk before in other parts of the world. Many people have mentioned that they still don't have access to brentuximab, and it's just not available. And so I know in many areas, the standard of care, still remains the combination chemotherapy. And that is really just what is available and tends to be cheaper overall because it's traditional cytotoxic chemotherapy that has been available for many, many years.
Awesome. Thank you so much for that answer. I did have another question as well. Are there any particular patients or considerations that come to your mind when you think about maybe pursuing a stem cell transplant earlier in the treatment course than what might be done for a standard patient?
I'm sorry, can you repeat that again?
Yes, I wanted to know if there were any patient demographics or considerations that come to mind for you that would push you to pursue a stem cell transplantation for a patient earlier in their treatment course.
Yeah, so I think, when someone has refractory disease or relapsed disease and are a younger patient and are eligible for transplant, it's always best to take, and are chemosensitive, then it's always best to do salvage chemotherapy and take them to transplant, because that offers the higher chance of cure. But if your patient is older, is not transplant eligible, or has disease that is not chemosensitive, then you're sort of stuck having to navigate the different combinations of salvage regimens. And the problem was that is they may not have as sustained of a response as transplant. So I always feel like younger patient, chemosensitive, eligible for transplant, that's always best to take them for that. Because, for Hodgkin lymphoma, we don't really have many other options. Like we don't have CAR T, for example, because there is no CAR T against CD15 or CD30 markers. And the problem with a lot of salvage therapies is that patients can relapse. And then once they relapse, you don't really have many good options afterwards. So take to transplant if you can, if they're fit, if they're eligible, if their disease is chemosensitive.
Understood. Thank you so much. I will take a quick break and see if there's any questions in the chat or any
Dr.
questions from
Abuali.
any of our attendees.
Dr. Winford.
Yes, I think I hear you. Go for it.
Yes, so we'll want to begin by thanking Dr. Abuali for such an insightful and highly instructive talk, really. And over here in Cameroon, we do have a couple of questions. So we're going to start with Dr. Tumsi.
Hi, good afternoon, and thank you very much for this very interesting presentation.
You can just
Hello, good afternoon, and thank you very much for this interesting presentation. I'm Dr. Tumsi Tontu. I'm a clinical oncologist. I just want to highlight that we have in our setting, and then probably follow up with a question. For example, we do not have access to FDG PET-CT in the whole country, so we rely heavily on just the best we can have is a CT scan. And so in terms of assessing treatment response, we have to do it clinically by feeling and measuring the size, or radiologically. And so we cannot adapt our treatment based on, the PET-CT. So in this kind of context, what sort of advice would you have for us? Are there any other modalities, maybe interval ESR or LDH, that one can maybe use to adapt subsequent treatment for our patients?
Thank you. Yep, I had the exact same issue when I was practicing in Egypt. I think at that time back then, we only had one PET scan for the entire country. And it was in the military hospital, and it was restricted for only a certain subpopulation there. But yeah, I used to struggle with the same problem back home. And the thing then you're forced to do is the only thing you can use for interval follow-up is just a traditional CAT scan. And because you're not really able to adapt based on the avidity on the PET, it's a little harder to de-escalate the treatment. So what we would often do back then is, you know how I said you can give, 2 cycles of ABVD and then de-escalate and just do the AVD. What I often would do back home is just do the full 6 cycles of the treatment. Like you can't really de-escalate and you want to catch the whole disease. And so you would err on the side of giving more rather than de-escalating inaccurately, because the only thing you have to go by is just the plain CAT scan, but it's not as easy to adapt response based on that alone, because you're not able to assess for avidity, you're only able to assess for size. So it's really just CAT scans and giving more treatment rather than less, because you don't want to de-escalate too soon.
All right, thank you very much.
Any other questions? Dr. Abuali, thank you once again. This is Dr. Chinda. So I had a little question. Like when you read around about Hodgkin lymphoma, one thing that popped out a little bit was alcohol-associated pain. Now, it is mentioned to be somehow specific, but I was wondering just how common is that in your practice? Do you often see that, and how strongly do you associate it with Hodgkin lymphoma? And my other
Yeah.
question, which you kind of a little bit alluded to already, you actually talked about it already in your talk, was about fine needle aspiration and how it's so not helpful in the diagnosis of Hodgkin's lymphoma. And in our case, you get a fine needle aspiration after 24 hours, but you get a biopsy and histopathology after 3 weeks. So that takes a long time, and a lot of time we go straight ahead to do fine needle aspiration first. So what kind of comments do you have on those two concerns?
Yeah, so the alcohol-related pain, I have always heard about it since I was a medical student, and I feel like it's one of those urban legends. I don't know, honestly. Um, I don't know one way or another. I don't know how true or how accurate it is, so I am not sure. Um, the fine needle aspiration point, yes. So as you know, I think we adapt a lot of our approaches to our resources, right? So what I would do if I'm in a I'm in a resource limited setting, and I know the biopsy is gonna, and the histology is gonna take 3 weeks to come back. Sure, you can do the FNA if it's positive, it's positive, but you still have to do the rest of it. Like a negative FNA would not rule out the disease. So I understand if you want the rapid turnaround time and you got the FNA to see if you can get earlier answers, that's great, but it's going to miss a lot of patients with the disease. So you still have to do the biopsy as well. So I would do both. I would not use it to rule out, but I guess you can use it to rule in and know that at least, oh, well, okay, I got lucky and it picked up the Hodgkin lymphoma in my patient. But for a lot of patients, especially for Hodgkin lymphoma, it will miss it. So you're still stuck waiting for that slower turnaround time. But there are really no easy answers when we're so limited by the resources we have. I totally get that.
The last question I had, thank you so very much for your answers. The last question I had was about one of the things we dread, as with malignancies sometimes, is malignancies occurring in someone who is pregnant, so in a pregnant patient. And a lot of times what we've encountered here has been breast cancer and pregnancy. So what about Hodgkin lymphoma and pregnancy? How would you advise we navigate through that?
That's a good question, right? Pregnancy with any malignancy is really hard, and a lot of it depends on when is the malignancy diagnosed, as relates to your pregnancy. So, for example, if the malignancy is diagnosed in the third trimester with someone who's about to deliver, can you safely wait until that patient delivers and then you can treat them? But if the malignancy occurs, for example, in the first trimester, then it's always a risk versus benefit discussion, because you may not be able to wait 9 full months, right? Especially if the patient has something like Hodgkin lymphoma. But then a lot of our therapies are toxic to the fetus. So then what do you do? And that's a discussion that has to be had with the mom about how long can you wait safely for, and whether the therapies are even compatible or not with the patient being pregnant, whether there is any way to modify the therapy. We treat a lot of pregnant patients with breast cancer, and there are some treatments that you can use while the mom is pregnant, but it's just much harder with the therapies that are used for Hodgkin lymphoma. So it's really a discussion tailored based on where the patient is at in their gestational age, and what therapies you can use and what accessibility you have to other therapy modifications where you practice.
One final question from Cameroon, if you have the time for it.
Hi, Dr. Abuali. Thank you for the presentation, for the lecture. I wanted to find out, you mentioned that not everyone needs a bone marrow. In your setting, I'm sure you can do PET scans and see bone marrow involvement. Since we don't have PET scans, how do we determine who needs a bone marrow in our setting, and how does the therapy change?
Yeah, excellent question. So yes, we don't do bone marrow biopsies here because we have the privilege of having PET scans easily accessible. But if you are in a setting where you don't, especially for patients who have advanced stage 3 or 4, and have CBC that is abnormal, so they have evidence of anemia or thrombocytopenias, then you most likely end up having to get a bone marrow biopsy just to rule out involvement. So you may not necessarily need to do it in every patient, but I would definitely advise doing it at least in patients who have abnormalities on their CBC to definitively rule out bone marrow involvement, since that will affect the treatment that you give the patient and what stage they are at.
Thank you.
Thank you. I think that's all from Cameroon here. And thank you once again. And thanks for sharing your expertise.